Very good evening to all of you. I think we are just end of the day. And first of all, I would like to thank all the organizers and even my team for giving me this opportunity to discuss on this various, although Sir has given a very extensive lecture, I think I just thank Sir that he has done half of my work. But I'll be focusing on few of the different parameters. Sir has discussed the key updates on the case, but I will be focusing more on the two major paper. One is the INSPIRE study, and other is the President study. So, I am basically I'm Shweta Arora, medical scientific liaison from India. I represent from medical team India government team for all the key activities I'm responsible for medical team. Different types of papers when we talk about. So today I'm going to discuss about, we read different types of papers like scientific review articles. Sir has discussed a number of papers. Even the other speakers, they talk about meta-analysis, research papers. But now INSPIRE study when we talk about is an expert opinion paper, which I'll be talking about. And this is one, as a research scholar, this is one of my favorite paper because it just talks about whatever already has done and just to see whether it resonates with the actual clinical practice or not. So experts, when they sit together, I think we have an expert who are sitting just in front of us. And when I'm just learning from them, when they are discussing after every talk, I'm learning a lot from them. So I think expert opinions matters a lot. So INSPIRE is basically an expert opinion in which the Eastern practice meets the Western standards. They were the 10 experts across the east part of the countries as well as the western part of the countries. And basically, they talked about the super selective CTAs. So although in our actual practice, you guys are doing super selective tests only, but what is the impact of that? For the student learning, why the super selective seem to be much more better than the going hereby or the conventional regimen? And what are the best practices? Why to opt for the same? So experts, they were there there was an advisory board which was planned by the Guerbet team, in which there were the experts from Asia and Europe part of the country. They just sat together and they just prepared some guidelines on the same. So the rationale for discussing the super selective CTA is to maximize the anti-tumor effect and as well as to have a good efficacy as well as the safety. Any trial or anything we do it, we just our main aim or main agenda is to get good efficacy as well as the good safety of any technique or any drug. So these were the experts who were there, and we were having two people from Guerbet team. These experts they sat together, and someone from Europe, Japan, UK, all these were in that expert meeting. When we talk about in the ancient times, then as the sir also had discussed that we can do taste at any stages, although the guidelines now they have come, the TRL is also there, or they say that the taste to be focused at stage B, but I've seen that in the centers, people are doing tests across the stages, but so is there a bridge between all the stages, and we can try various combinations with taste with RFA. We have discussed that ablations or taste with some of the radiotherapy and all these little artistic things. So that we'll get what is the main agenda at the end of the our procedure is to get that patient to just downsize the tumor and as well as it should not recur and patients should lead a well life over the period of time. So this study discussed that taste can be a choice to all stages, which is not, I don't find, I mean, as per the experts' opinions, it's not true with it. All the stages depends upon the severity and the end results or the long-term results with that particular procedure, or we are trying the combinations therapies in the same. So, as Sir has discussed, and thank you, Sir, I mean, it has updated, and we can now have a pair also, but for the stage B, the BCLC staging says that you can do the test at the stage B till the stage B, and maybe even in bridge study was saying that it is to be done across the stages, but this classification says that that the category B or intermediate stage is the best stage. Although the standardization of the test, which I find when I had a discussion with the key experts across the country, they said that still for the India specific, we should have some recommendation of the guidelines. You guys are doing wonderful work, but it should come in the paper, which will give us, I mean, an edge to our country that we are doing a superb work in terms of various interventional procedures. So, what does the paper talks about? It talks about the introduction, what is the patient selection, the treatment delivery, what are the outcomes in the same, and also it talks about the post-treatment, uh, what is post-treatment care and imaging follow-up. So first a statement which they said is that it should be delivered at, in fact, the most significant process of CT is it should be super selective in the scenario and as well as delivered at subsegmental by microcatheter as far as we are, but we are close to the tube. It's like we are reaching our enemy, but very safely. So you are hitting a gun, your target should be so selective. Suppose a soldiers are there. One is your soldier and one is your enemy soldier. Now it's very difficult for you to identify which is your soldier and which is your enemy soldier. You have to hit very selectively. So it has to be super selective, protecting your own surrounding healthy liver parenchyma. So that is the goal of this thing. So they suggested that it has to be. So this line I really like it. This positioning of the catheter as distal as possible and close to the tube. And super selective CTs, so it depends upon the size. When we talk about the standardization, it talks about they discuss that from 5 centimeter to up to that scale 7 centimeters. You can go up to 5 nodules and 2 to 4 segments up to we can focus on the same. Then they have also analyzed this few of the studies they have seen and reviewed that for maximum super selective were done for the single nodules and the range which would they have selected for the taste was from 3 centimeter to 5 centimeter. Although I've seen that in few of the cases, taste has also expanded to 7 centimeter or beyond that. So, but they could able to get a certain scale or certain standardization in which they have fixed this from 5 to 7 centimeters. And additionally, they talk about selecting a safety margin, although it's a little difficult task in selecting a safety margin if the tumor size is too big, too small, or suppose like that. But if you are selecting a safety margin in the same, then the recurrence of the tumor, local tumor progression seem to be little lesser. So as the size of the tumor is more, the safety margins are also has to be selected little more in size, so that the end aim is to prevent the healthy parenchyma to not get damaged due to the taste. Then the other thing that is everyone knows that the angio-CT is very important tool which is to be done to take the where is the tumor, how much is the size, where we have to target. Suppose for whenever we are going for the soldiers are going for a war, they just see with the binoculars, so this is defined, they make a map. Let's see that this is the position of our enemy. So the tumor is treated like that. You have to first angio-CT is to be done to see where exactly is your target location. Then the size of the catheters which to be given, they have also selected about 1.5 range to 2 that they have that maximally it syncs with your clinical practice, and semi-rich positioning they have encountered because just to protect your or be little more protective in this case, protect your liver parenchyma and to reach your location a little fast to your target, and to be slightly pulled back for the final addition embolization. Then this is good. I think whenever we are talking about the taste procedure, we're using of lipidol in the case. So water in the oil mixture. So we can see this. So this is for the students. You can see. So water in the oil. So we mix like this. We have a 3 or 4 stock box which we can use it. So we can mix the water in the oil emulsion we can prepare, and we can give the 20 to 25 pushes into the same. So see, the water is mixing into the liver oil, and there is a proper emulsion formation. And you can check your emulsion by the drop test. And the ratio which they usually give it is 2:1 or 3:1 of liver oil versus drug ratio. And we can see the drop test also here. See, if the drop is proper, we can see the drop. So if it is, we get a proper drop, it is done in the saline solution. So we just put a drop. If it is formed properly, that means your emulsion is seen to be. And you see this. This haywire is in. survival is not a problem of this emergence. So next. Okay, so last, when we are, final closing the door with the gelatin sponge, if it is used additional fetal embolization, so that is always recommended, and it was the study which they have seen was that if you finally do the additional fetal embolization, then the survival rates are more, pregnancy rate are less. In this case, that is important. And after that, once the phase is done, then we have this non-contrast to check how much is the tumor access, how much is the overall, what is the effect at the end, final CBCT which we do it. Then they have seen that the DASR was also discussing that the CTs, what is the time duration which we can follow up? So median survival when we can see the tumor, and we can either club it with the ablation. And super selectivity, which we have discussed, that it decreases the rates of adverse events and it improves the tolerance over the period of time. And if the patient is landing into more severity, then you can do the combinations of the various techniques to get the downsizing more properly over the period of time. Then reflectiveness, which the sir very well have described, that if in the two seated response, we see it's not working, or if there is a reflectiveness seen, in which he has also discussed some molecular mechanisms which are responsible for the reflectiveness. If it is seen, then I think we just take a it was the study, or there was a survey which was done at what time, or till what time you can see whether you can stop doing it, or whether it is working properly or not, showing effect or not. So twice they will try and see whether the downsizing is there or not, or whether there is a refractiveness or there is no refractiveness. That is checked. So no response after 2 super selective sequence within 6 months is considered to be the phase of refractiveness, and patient should be treated with super selective until they are considered to be unstable. So we'll select them to the same. Then the contrast enhanced CT is also very much beneficial, and MRI. I was reading about LiDARs also, that is also coming in the current experiences or in the current clinical practice to check the how much has improved or how much it has declined or what is the downsizing of the fact. Even though the other parameters like AFP or the which we're discussing in that recent, which is updated in the VLCC classification 2023. So they have added into the same. So many of the parameters we will check it once we see whether what we have done has really affected or not. So this was the INSPIRE study, which talks about the super selective and various consensus which were discussed, what were the pre-things, post-things, and now they have also discussed about now they have compared in the president study, which was done in approximately 200 patients, and 100 patients were there in DEPTAs as well as the CTAs. So they have compared both the techniques by using the CTAs, the Padol and DEPTAs beats of 100 to 300 micrometers, and they have seen that they've used the embricic criteria in which selecting for the response of the case. What they could able to see that both were performed super selectively, and the complete response which was seen more better with the case of the CTAs versus the DEPTAs. More number of the patients when we talk about. So CTAs patients were 75% of the 3 months follow-up. This is 1 month and this is 3 months follow-up. 75% of the patients, they were showing the complete response. As compared to the DEPTAs, the response was a little less. And the results were going to be statistically significant with a lesser than p-value of 0.005. So why it has happened? Because of the response is more, and we have also discussed in the studies, which were precision study, which sir was discussing, that the response was not as much as good. Because when we are talking about a big tumor or a enhanced one, then what happens in the DEPTAs, that with the DEPTAs, it works only on the, not completely moves inside it works on the arterial branches, not on the venous part, or not, it doesn't enter into the sinusoids and all. Whereas a lipidol has a property of just, just spreading like anything. So it's just the example, when you are putting oil in sometimes what happens, the oil spreads in our room. How the oil spread? Entire floors become oily. So it's like that only. So if oil just spread very, even though the viscosity is far lesser, it's very thick, but still it spreads completely too sharply. So it just covers all the collaterals, all the veins, arteries, sinusoids. So the effect that's why the complete response is seen to be much more better in the case of the CTase versus the DEFTase. And this, even I discussed with many of the experts, they say that it slows, and the beads, when we talk about it, it takes little time to just show their effect, and they are a little slow in their effect, slow and steady type of character of the beads as compared to the lipid oil. So this is all just to summarize everything, that it has to be super selective. And when we compare both of the things, I think we have defined the parameters on the basis of the RCC modules, either from ranging from 3 centimeters to 5 centimeters, then on the basis of catheters, water in oil immersions, then how you can check the endpoints at the end, how much is the tumor, safety margins plays an important role, contrast imaging plays an important role. So everything put together will give you a final result. Small stepstones when we go, and then at the end we'll get the full results. So we have to be very cautious and clear, and it's just moving one ladder to another ladder and getting the best result out of that. So encourages the super selection, hitting the target properly, and also multidisciplinary decision making, which our experts in India are already doing it multidisciplinary. I think our upcoming IRs will also follow this multidisciplinary decision making, which will give our country as a better, very bright intervention radiologist as well as the DIs in upcoming scenario. So that is the first presentation. Now I'll just take a 10 minutes for the other presentation. And then we can have discussion. Next is about we'll talk about the gadolinium-based contrast agent, and then the linear versus the macrocyclic one. I'm not going into much more details of the things, but there are various linear versus the macrocyclic agents in the market. I just start with little bit basics about the gadolinium. I think it's one of the metal which is found to be having intense imaging properties, and but initially the era has started with the linear, and over the period of time we moved to the macrocyclic. I think our experts they know that how the era has changed the world. I mean, from the linear one and the macrocyclic one. In the US, there was a lot of things that a lot of side effects or NSF cases or brain hypersensitivity cases were seen when we have compared the linear versus the macrocyclic. So gadolinium, what is the effect? Why it is toxic? The major, I'm not going to remember much of the details is the same, but it blocks our calcium channels. I was reading in the papers that it was saying that the gadolinium also interact with some of the important biological processes in our body, and it impacts, and so it is very toxic. It should not be moving in free in the body. Whenever any of the EM waves goes inside the body, our protons, they start displacing from one place to another place. So for getting them back, we want to have that getting them back to the proper place. Once they are displaced, at that time we'll have the T2 relaxivity, and once they just come back, it is T1. So we are taking the T1 pictures, which will give us the intense pictures, better images once it is back. But the concept lies in the fact that gadolinium should not be free. If it is free, it is interacting with the calcium agent. It is also impacting the other important biological processes in our body. So it has to be structured, it has to be caged, it has to be chelated. So either you have to do the chelating like a linear means as we used to do in our mathematics, linear equations, simple, straight one. Whereas a macrocyclic means you are just putting it in the cycle form or in the structural form. And when you are putting the gadolinium in the structured form, that means what you are doing, you are making that particular structure as a more stable. Living in a hut or living in a villa. So both of the things you see, in which of the things you will find it to be more safer and secure. That means you are living in a villa with the full, all amenities and everything into the same. So that's what it is, that it is less toxic when it is macrocyclic as compared to the linear one. Reduce proton binding, and as well as improve tolerance. So when it is macrocyclic part, then the kinetic stability part increases. Stability increases, that means the gadolinium will not come outside from that macrocyclic structure. If it is more of that is called the kinetic stability, it will not break, it will not become toxic, even though it will give the good images over the period of time. Thermodynamic stability, ionic versus non-ionic. If it is ionic, that means it is negatively charged. If it is negatively charged, it will not interact with the proton ions, and the negative and negative, it will not interact with each other. Most of our cells, they are negatively charged, so it will not move inside the same. So thermodynamic stability means for the ionic cases, it will not break. It will be more stable at a different pH. It is negatively charged, whereas the neutral ones will be non-ionic ones, and they will be less stable as compared to the ionic one. So higher stability of gadolinic acid minimizes the risk of the gadolinium, and chelation always helps, transmetallation always helps, and it is more resistant to transmetallation, which is none other than when the gadolinium just breaks and comes out of its form, then it is, and it becomes toxic, then it is called the transmetallation. So chances of transmetallation, they are far less with gadolinic acid 0.5 with the macrocyclic agent basically. So when we have formed this, so if it is not in a toxic form, there will be lesser cases of NSF, and also there will be lesser brain hypersensitivity signals will be lesser. So how I learned this ionic linear MMOOTGP. So I formed this ionic versus non-ionic, linear versus macrocyclic. When you see the dotatum or the galactic acid falls in the case of ionic and macrocyclic, that means it is kinetically as well as thermodynamically stable molecule. And there were no NSF cases and brain signals were seen. So inert molecule, highly soluble, high hydrophobicity, as well as excrete unchanged by glomerular filtration, no biotransformation, do not cross the blood-brain barriers. That's why the lesser of the brain hypersensitivity is a little lesser. And excretion half-life is about 1.5 hours, and no specific drug interactions. PK/PD parameters are quite safe. Then I just discussed that it will not pass the blood-brain barrier, and it is very safe in this sense because of ionic and macrocyclic ionic character. It will not. The negative ones are those molecules that are very difficult to pass from all the cells. So there is lesser, and also excretion rate is also a little bit delayed when we talk about the galactic acid. The half-life is more, but when we see, even though the question arises that even though there's so much of the half-life, but is it safe for the renal impaired patient? Yes, it is safe. We have done the study, secure study and rescue study, which I'm going to talk about in my next slide, which talks about rescue, that even though they have CKD 3 and 4 also, they are used compared with contrast and without contrast. So it was seen that even with contrast and without contrast, the results are seen to be almost comparable. So that's why we don't have never, even though so much of dosages encountered with galactic acid, still we haven't seen a single case of NSF, even if they have been ranged from pediatric to adult to across the ranges. So good safety profile, very no evidence of nephrotoxicity, which I said, no cardiac issues are seen, and ranging age from few weeks neonates to the adults of 1 to 3 years. So renal safety, which I was talking about, even it was tried in the GFR, EGFR less than 20, and but with a caution, as you guys are experts. So, but we have seen that that it is even with the lesser of the EGFR, it was tried, and it's 3 and 4 range. In our study, it was not, and 3-month follow-up was also seen, and it is seen that galactic acid was not responsible for any of the contrast-induced nephropathy. And this study which I was talking about, that they have seen how much is the serum creatinine rise over the period of 72 hours, and these 25% with the per target, and as well as EGFR values also, they just analyzed with both of the control groups without contrast and with contrast. And it was approximately 114 patients in which they have been split it equally in both of these scenarios. Yeah. So this there was, so that it is not much seen, and it resulted in appears to be safe, and there are no NSF cases. Still now we have not seen any of the NSF cases when galactic acid was used. Last secure study, which not only done in the case of the CKD patients, but also it was done across the ranges, across the ages, to see if there are any safety issues with gallitoric acid or not. But they have seen and it's a huge data, and it's a 5-year study of 35,499 patients, which talks about that the goal was to see the safety among the different age group, different set, and they have done MRI in different scenarios like renal, cardiac, and many of the indications was done. And what they could able to see that the efficacy was superb, that 99% of the good images were seen, and there were no such safety related concerns were seen when the gallitoric acid was used in this set of patients. Almost safe. See, the 0.1% of adverse events, and even though the adverse events were transient and quite manageable, and no NSF cases, and efficacy was 99% of the MRI images. So that is it. It's a safe agent, and it's quite stable, safe, without NSF and without any brain hypersensitivity issues. That is from my side. Thank you so much.